Okay, so I'm going to start again. My name is Clivia Torres, and I'm one of the social workers at the Center of Excellence for Alzheimer's Disease, and I also work with the GWEP Bridge Program.
Hi, I'm Ting Cheng. I'm also a social worker working under Center of Excellence for Alzheimer's Disease Grant.
And I'm Andy Moise. I'm the caregiver support specialist. I work with Sunnyside. So I provide caregiver support services and resources for the family. So today we are going to learn a number of things in this session. So first we're going to talk about what is a social worker's role in this clinic, what do we actually do when we meet with the caregivers and when we meet with the family and the patient. Different programs that the family can use to better care for the patient. We have Medicaid programs, how to qualify for Medicaid, what are the eligibility criteria, and also the process to get home care through Medicaid. We have a number of social services in the community that we usually refer families, and also a very important point also advanced directives. So we're going to talk about all these topics and some more. So we can, and if you have any question at the end, we'll take the questions at the end so that we can just go to the presentation.
So, our roles in this clinic in particular, Clivia and I usually join in for the initial assessment. We think it's important for us to take part in the caregiver's input when they share about the history of the patient's like history, memory loss history, and what are the services they may need, and so we can connect them with the right resources. Anything you want to add, Clivia, with the roles before
Basically, what we try to do is, we do try to sit in as many of the of the case studies that are being performed or evaluated, the patients that are being evaluated on a given day, because it's really up to us to connect with the family, the caregiver, with the resources in the community.
Okay. We get the most question when we sit into the interviews. This is the most, I think, urgent needs from the family members. They always wanted to know if they can be receiving help from like getting the home care in the home, so they don't have to take off from their work. And a lot of time they don't have Medicaid in place. They do have Medicare. However, with Medicare, there's only a very limited services provided for seniors. So with the partnership with Sunnyside, we were able to refer, make the referral to Andy, since they do have a Medicaid specialist that can guide them to walk through their income and help them apply for Medicaid in the end. So Andy will explain the process of how to get the Medicaid.
Right, thank you. So one of the first things that people who don't have Medicaid is because the reason they don't have Medicaid actually is because they don't know whether they qualify, or they always think they don't qualify. As you can see on the slide, the amount to qualify for Medicaid is $875 per month for an individual, and for a couple it's $1,284 a month. So most people fall over that category, and therefore they think that they are not eligible for Medicaid. But they can be eligible for Medicaid. They just know the process and what to do. And another thing also that they look at is also assets. So if a person has more than $15,750 in assets, total asset, that's including if they own a second home. So that actually well over the limit. So they think they don't qualify. So one good piece of information that we try to provide everyone with is actually a pool income trust. So when the income is over the limit, they can apply for a pool income trust. So which means that the excess income can be used to pay the bills and not counted towards the monthly income. So that way they will be eligible to apply for Medicaid with a pool income trust. So that's the income portion. So the asset portion also, sometimes people will ask to transfer fund or work with a lawyer. If they have a large amount of assets, we recommend them to speak to a lawyer to actually manage those assets. But primarily, a lot of people, they own a home and they are living in their home and they think they do not qualify because they own a home. But under Medicaid guideline right now, if you own a home and you're living in the home, you can apply for Medicaid. So that's an exemption that they are making because they're not going to kick you out of your home to get Medicaid. So you're allowed to have a primary residence under Medicaid, and you can still have all the services for Medicaid. They are also advised from lawyers that you should not leave the home in your name after you apply for Medicaid and you're getting the services. That is pretty good advice. So we also inform them about that as well. There's also the other part where one of the spouse is required to have Medicaid and the other doesn't want any Medicaid services or home care. So, but the spouse aspect is preventing the person or the patient that we are helping to get Medicaid. So that's the problem that we have. And this is why right now in New York, so we are able to do spousal refusal. So right now it is still possible, although that there's a debate about whether or not it's gonna continue or not. But for now, I think this is still possible. So the spouse can refuse to use their asset and income for the eligibility of Medicaid. So that's one of the things that we also inform families when they are contemplating whether or not they should get Medicaid. And primarily, we want to do this for those who need home care, which is like a majority, or if not all of our patients who need home care, because home care is actually something that can cover, that can give the caregiver a break, long-term services. So that's really necessary to have home care in place. And in order to get home care, also, most people have to join a managed long-term plan. There are several of them, but they have to choose one of them to get the long-term plan. There are other options other than using the long-term plan, but most people do use MLTC. So in order to be eligible for home care, even though a person has a diagnosis of dementia, but there are other things that they look for to qualify for home care under the state guidelines. You have to have some needs in activity of daily living and instrumental activity of daily living. So for our patients, I think primarily the safety concern is really one of the criteria because the person wonders and we are concerned about that. However, Medicaid in New York State, that's not one of the requirements. So the safety concern is not, they have to have like physical limitation that will qualify them to get home care. So, but we do work with the family. We explain what they need to do and how to get the Medicaid. And we help a lot of people getting Medicaid home care. And there's also another way of getting home care by having a family member work with the person, because we do have some people that do not let strangers in their home and they don't feel comfortable with that. So there's a CDPAP program where it allows a family member or a friend or anyone else that the person is familiar with that can work just like they're getting home care, but it's just like they're getting to someone that they know and somebody they're familiar with, or whoever the family wants to hire for that. So that is also possible. And I think my colleague maybe talk about some changes in Medicaid coming in October.
Yes, actually, the spousal refusal, I know right now that it is in discussion, because I know in New Jersey, you cannot use spousal refusal. So in New York, I think they're trying to copy the same pattern, that people that are married are not allowed to say, I don't want to help out my spouse. So that's something that right now is being discussed. Okay, like what Andy mentioned is like when people have excess income, that's something that Tina and Andy and I, we've been talking with the caregivers, that If the patient has income that is more than what's allotted, but they don't want to apply, then they should definitely try to use the income that they have for the patient, meaning trying to hire, if it's private pay, home care. Because sometimes what we find is that there's somewhat of a resistance with the caregivers wanting to use the money for the caregiver services. So
And yes, and I forgot to mention, put on the
Seems
slides.
like, sorry to interrupt, it seems like that change is, the main outcome is going to be a spike in divorce rates, right? Rather than a...
and it's possible, and it really is
Yeah.
possible that that can happen.
I mean, it's just another workaround, right?
Right.
Uncontested divorce.
The challenge is also that sometimes when people come to our clinic, they are married, but they're not living together. They may be separated. And even if that's the situation, they will still count the fact that the patient is married, and then they will count the person's income. So it is a difficult thing.
Yeah. So I wanted to add for the Medicaid spend down. I forgot to put on the slide. So if a person is receiving a monthly income of about $1,000 and they want to get Medicaid, usually we'll probably suggest them to get Medicaid spend down, which is easier route. So that means that the state will take away $125 and they will be qualified for Medicaid. When the person go to Medicaid office, they usually won't be offered pooled income trust. They will not inform them there's an option. They usually said that you just have to give out whatever left over to the state and you will be qualified for Medicaid. So if a person, because with the pooled income trust, there is a fee, annual fee. I believe it's like 10% to 15% of whatever amount of money you put in a pool trust. So if you have a lot of leftover, probably pool trust is a good idea. But if it's only $150 of leftover, probably spend down is a easier route. And with the new changes, I know presently with the community Medicaid, they don't look back your income. Like they don't look by your last month income if you're applying for Medicaid. But I think for this coming October, they're looking back 2.5 years of your income for the Medicaid, community Medicaid.
So
Yeah, and also,
go ahead, Andy.
yeah, and also some things are gonna change about the assets. For community Medicaid also, they don't really look back of asset for the previous month.
Mm-hmm.
But we heard that in October also, they're gonna start to look back on asset for community Medicaid. Usually for nursing home, the look back is 5 years. But now they're saying that for community Medicaid, they're gonna look back for 2.5 years. So that is some change that is coming in October. So I mean, we have to wait and see, but that's something that they are thinking about.
Mm-hmm.
E.T., can you just go back to the previous slide?
Oh,
I
yes.
just wanted to mention something about the CDPAP.
Sorry.
It's okay. While the CDPAP program is very good for most of the seniors that do not want a stranger in their home, there are some challenges with it, because if you have a family member that is taking care of your loved one, sometimes if the person calls out, there may not be a backup for that patient that day, unless you already have it set in place that you're going to have a backup. The challenge also becomes that sometimes the family member is not providing the services that really should be provided for the patient. So that's a concern sometimes for some family members. So while it is a very good program, it does have its challenges with it. So families really have to monitor the situation to ensure that the loved ones or the patient is getting the services that they need through the CDPAP worker. Okay, you can move on.
So as Andy mentioned earlier with the nursing home Medicaid, they do look back 5 years of your assets and your income. So most of the family that come to our clinic, they usually start with the community Medicaid, which now they don't look back until probably in October that would change. There's another option. We now refer a caregiver to, it's called nursing home transition and diversion program. We actually recently got trained by one of the agencies, and they share with us that this program actually allows the patient to receive more home care hours compared to the managed long-term care plan. And the only difference is that they pay through straight Medicaid. So that means that if a patient is presently receiving managed long-term care Medicaid, they will have to switch to straight Medicaid, and that would be a big change in terms of healthcare provider. If the provider is not taking straight Medicaid, they maybe have to start the care to, find some other provider that do take the straight Medicaid. However, in the long run, they do get more hours, at least from the experiences that we have with the patients. They were able to get 24/7 care without too much hassle or a lot of back and forth with the home care agency. And the criteria is about the same as the managed long-term care plan. You have to be eligible for nursing home level of care, and you are authorized to receive Medicaid managed long-term care like level of services. So the transition from managed long-term care to this program is about 30 days to 60 days. So Clevia and I, we do refer to this program a lot. And I think Cleva has a family that's actually ended up getting 24 care,
Yeah.
right?
Yes, I did. And the good part with this program is that they don't provide, like, let's say, 1 or 2 people for like 12-hour shifts or 24-hour shifts. What they do is they tend to break it up, like 3 8-hour shifts if possible. They understand that they may be difficult for the patient, but what they also don't want is for someone to be in the home, be tired, and not provide good care for the patient. So that's what they do. They usually break up the 24 hours per day with hopefully within 3 workers.
And there's a benefit for doing the nursing home transition and diversion program because, as the name suggests, it's avoiding nursing home placement. A lot of time when people don't have enough hours, they're not getting the proper care. And what's going to happen is, like, if they deteriorate, they're going to go into a nursing home, and which sometimes the family doesn't want, or the person never wishes to go to a nursing home. So we work with the family to see what is their wishes, and we refer to this program so that, we can avoid people going to nursing home. Some people may need 24 hours, they're not getting it from MLTC. So that's a great resources that we use to avoid that.
For Medicare, so as we mentioned earlier, Medicaid, they don't provide long-term care. So eventually, if patient needs a long-term care, they will have to start the process of getting Medicaid. With Medicare, they provide short-term skilled nursing, like wound care. We can make referral to VNS, and they will be able to send like a nurse to check on them or provide some sort of behavioral management on like once a week or twice a month basis, but not a consistent like a service. And there's also respite care. Andy?
Yeah, so respite care is actually a way of giving the caregiver a break. Most of the time, some caregivers are overwhelmed. They are doing this 24/7, and they have no time for themselves. So we usually provide in-home respite or adult day program respite. So in-home respite, it could be a home attendant for 4 hours or 8 hours a day, 1 time a week or 2 times a week, just to give your caregiver a break, some kind of relaxation. Some caregiver need to go see the doctor too. So that's a great way to help them, because when the caregiver is healthy, they are able to do a good job, but when they're not taking care of themselves, so it's not a good situation. So sometimes they use that. And also, people applying for Medicaid, they have to wait some amount of time before they actually get the Medicaid application approved, do the MLTC, apply for MLTC, and also getting the home care. That's a 2 to 3 month process. So giving them the respite for that time is actually a great way of helping family caregivers. So we do that also. And there are other organizations that are giving respite, just as we are doing. The Caring Kind also give a grant for respite. And there are also other organizations that are using respite services. Some people who have managed long-term care already, or they're already getting home care, they do not qualify for the short-term respite that we provide because we are funded by the state. And so Medicaid also is a state program, so there's no double dipping. But they can also get respite. So the MLTC provide respite. For example, caregiver may need to go on vacation, or they maybe go away for the weekend or for a week, or maybe they are so overwhelmed they just need a break. So the MLTC can provide respite for a short-term placement in a nursing home, and they can use that, I think, a couple of times during the year. So this is also another way of getting respite, even if they have home care in place. And also, I wanted to mention also adult day respite. So sometimes we can, the person can go to a day program where they offer socialization for the person, and they stimulate the memory with activity. And while the person is attending the program, so the caregiver have a break. So that's another way of providing respite with the short-term respite for the caregiver support services.
So I'm sorry for interrupting. So if I understand correctly, so there are three types of respite. You can have one where there's a short-term placement in a skilled nursing facility or nursing home. Two, you can have maybe like the patient going to sort of, it's an outpatient day program. And three, you can actually have someone like a home attendant coming to the house. Are those?
Yes.
Okay.
Yes. Okay, Clivia, are you going to talk about adult protective services?
Yes, Eaton and I will talk about that, but Eaton and I tend to call adult protective services when we have concerns that the person may be financially exploited, being neglected at home, or just being taken advantage of. Sometimes it's easier for us to just make the referral online because we know that it is accepted. With adult protective services, if you call into their office, sometimes they can tell you right then and there that the case is not accepted because they don't have enough grounds to accept the referrals. So what we have found is that when we do it online, they can't get back to us right away. So they actually have to go into the home to do like an assessment. And, we have been lucky that some cases have been accepted and APS does get involved, but we also have been very unlucky in that some cases that we have called in because we actually have grave concerns are not accepted. And then there's another agency called the Elder Abuse Center, which is an organization in New York City made up of like 6 or 7 different organizations. So like whenever there's a concern that we have about a particular case, we can reach out to this group and they can actually contact the APS worker to sort of intervene and find out what's going on with the case that we have referred, especially when it's coming from the hospital. So, Eaton, what else?
Yeah, I think a lot of times I get pushback because they would say, oh, there's a caregiver involved. So if the patient is not qualified for this referral. And so there are multiple times we have to repeat to make referral 2-3 times until they actually accept and intervene. Yeah, I just, sometimes you just have to be persistent with them.
Yeah, and we have cases right now that we've called in like 2 or 3 times at different times just to make sure that they continue to go on to visit the home, and finally they do accept the case. The challenge we have is like with APS, the worker that's going out to do the initial assessment is not the worker that's going to follow through on the case. So the first worker just goes and says, there's enough reason to accept this case as a case that needs to be monitored. It gets transferred to another worker. The challenge is that sometimes those workers don't call us, although we are the referring agency, and they don't follow up with us to let us know what's going on with the cases. So that's sometimes the frustration that we encounter. But we do know that for the most part, we have told the family members that we are calling adult protective services, and we explain to them why we're doing it.
Mm-hmm. Yes.
So, do you know, is there a difference between APS and Department of the Aging?
Yes, there is a difference. APS is like the agency that you call when people were being, seniors being, let's say, exploited. It could be physically, verbally, sexually, emotionally, psychologically. So that's the agency. It's like when you're working with children that you will call child welfare.
ACS, yeah.
Yes, so it's sort of the same thing, but this
Or
is
neglect, right? To neglect.
Yeah, the neglect.
and neglect, right? Thank you, Dr. Reinhardt. And you can also call for neglect. And then the Department of the Agency does monitor a lot of the senior centers. They monitor a lot of the programs that are geared for the seniors.
Mm-hmm. Yes.
So like we cannot refer a case to the Department for the Aging that is involved neglect or let's say elder abuse or something like that. That we would have to go through adult protective services. And as social workers, when we're at the meeting with the doctors, sometimes we're the ones that do the referral in conjunction with the doctor. But if there's ever a case that, you know, needs to be referred and the social worker is not available, then the doctor, and if I'm not mistaken, a resident, I think, can do it. But I know students can't just do it on their own because you need to let your supervisors.
But Clivia, it's Shirley. Isn't it? Aren't most providers, licensed providers, mandatory reporters?
Yes.
Yes.
So they don't have to go through their supervisor. That's an institutional policy.
Mm-hmm.
Mm-hmm.
Yeah, because
So
I mean, I know.
just to clarify, in New York State for elder abuse, providers are not mandated reporters. Right. We're one of the few states in the union where that is not the law.
Oh,
We're only
wow.
mandated for children, not necessarily for adults.
Unless you work in a long-term care setting.
Right.
Oh, that's fascinating. We need to do something about that law.
If by fascinating you mean awful, yes.
You know, you can also call cases in anonymously if you don't want people to know that it's you that's calling, you know. So, I mean, I've referred cases, you know, to APS both ways, but, you know, that is a concern that in New York, you're not a licensed, you don't have to, you're not a mandated reporter.
Yeah. And I just wanted to make a comment about the DISTA, Department for the Aging and Adult Protective Services. The Department for the Aging, they mostly deal with seniors of 60 and up, but APS, it's 18 and up. So, and so Department for the Aging usually provides services to older adults. While APS, it could be any adult, as long as you're 18 and over.
Mm-hmm. So I think for Department of Aging, it also provides Meals on Wheels services for seniors. If a patient does not have a home care, or someone who, I know they don't, they do accept patients who do not, or seniors who do not have a home care no more than 20 hours, they will be qualified for Meals on Wheels. And we can refer them to their designated district social service to start the process. And the only criteria for Meals on Wheels is they have to be homebound, means that they have to be in a home to receive the meals. And there's also another Meals on Wheels program called God's Love We Deliver. This is a little different from the city meals. This one, usually the doctor will have to make the referral because it's offered to patient with either HIV patient or with people with dementia. So they tailor the meals for this populations. And then with the mom's meals, I think Dr. Rao has positive feedback for this agency. I think they do cook good meals or more flavorful meals. So we put it up there.
They're a little bit more expensive, but most people that have used it do like it.
Yes.
And we were actually informed by one of our colleagues who's a social worker at SUNY Downstate that when she was using God's Love We Deliver, they were actually giving lunch to the caregiver that was with her mother.
Yeah.
So they didn't only take look into the patient, they were also concerned with the caregiver. Who wants to do that?
I'm sorry, so just for clarity, so who pays for the meals?
The Meals
So
on
for the
Wheels is free. Oh, sorry, Andy, you go ahead. Yeah.
No, again, that's what I want to say. Yes.
So
So
meals.
Meals on Wheels is free.
Right.
It's free. God's Love We Deliver. We do put the insurance information. However, usually they are able to provide it to the patient for free as well. All of their staff at God's Love We Deliver are volunteers.
Mm-hmm.
Yes.
And mom's meal, I heard a comment that it's a little more expensive, or
Yeah, that I'm not quite sure how to go about it.
okay.
Yeah. Clevia, do you know?
No, I know I've given the number to family members, because with a lot of these programs, sometimes they want to speak with the family member instead of a social worker.
Okay.
So in my experience, the mom's meals was covered by the managed long-term care company. I don't think there was any patient contribution.
Oh, okay.
But it may be dependent on insurance carrier, which of these vendors they work with.
Mm-hmm.
These, I think they consider them vendors or contracts, right?
Okay. So for transportation, a lot of family, they already have managed long-term care plan, then they do receive free transportation support to medical appointments. So usually it's a week before the appointment, they can set up the schedule, or they can also start the accessory application. In the past, you have to call them and they will be sending you an application and give you an appointment date. But now they are available to do it online. So we will usually direct this family to submit an application online. So accessory, they paid the $275 fare, and they can go any places. It can be a senior center, a doctor appointment, or any program they want to go, or grocery shopping, they can use accessory. But I think a lot of family didn't know that with the accessory, if you want to make changes of the appointment, only medical appointments, you can change it on the same day. So a lot of times we may go a little over the scheduled time, then we will call the accessory to let them know that please come an hour later, an hour later than the scheduled time. So they are able to make that change only for medical appointments. And then there's a Jewish community services, JCC of Greater Coney Island. They also provide transportation, but only for Brooklyn seniors residents only.
And with the accessory, some of our families don't like using it because it's a shared ride. And sometimes some of the families say that they wait too long for the driver. So like if they have, let's say, a 12 o'clock appointment, they may be picked up like at 9 o'clock in the morning, and then they have to wait at the clinic. Or if they finish by 2, sometimes they have to wait until 4 o'clock to get picked up. But we do tell the families to at least have it as a backup or as another option for the patient. And a caregiver can also accompany the patient when they use an accessory. Okay, so senior centers versus adult day programs. The senior centers are basically places that anybody over 60 can go and participate in the activities that the center has. Throughout the city, there are so many different ones, depending like in each catchment area. But at the senior center, the person can get breakfast, lunch. They can participate in a variety of activities that are held at the center. At the adult day program, we know that the patient gets picked up from the home, and he is they provide transportation to go to the adult day program, and he is then brought back via transportation. But the concern is that someone has to be there in the home to make sure that the patient gets on the right bus, and then that the patient is received at the end of the day. At the adult day program, no one can accompany the patient to the program, but at the same time, a home health aide or a family member can accompany an adult to go to the senior center. So what we do is when we have a family member that, a patient that comes in with their family member, we look at the borough, we look at the zip code, and we provide a list of both services. The senior center, like I said, it's free. Anyone over 60 can participate. And the adult day program, they use the Medicaid to pay for it. The challenge becomes that sometimes the family or the caregivers want their patients or their loved ones to participate in both. And that's really the contingent on the long-term managed care program that the family has. Sometimes they will not pay for both services. Ethan and Andy, anything else you want to add?
No, I think
No.
you covered.
The public libraries, New York City, they actually have a lot of services and a lot of programs for seniors, especially for those that are still like in the early stage or the mild cognitive stage of the memory loss. Okay, they can participate in them. They can learn how to use computers. They can learn how to do Tai Chi, yoga.
Yeah, yoga,
Yeah, and then,
drawing or painting.
right. They also have like book clubs that, go there and participate. So we try to encourage those of our family, the patients, if they're in the beginning stage of the memory loss, that they can participate in these activities. Or if it's someone that enjoy reading or something like that, we ask the caregiver to at least accompany the patient to the library so they can at least see some of the shows, because throughout the city, they do provide a lot of services.
Oh, sorry.
Go back.
So we also do a lot of referrals for in-home counseling support. A lot of time the family caregiver can mention that, oh, the patient doesn't like to go out and they don't like to interact. So OHEL, they do provide about 6 to 8 weeks, 6 to 8 sessions of in-home counseling to the seniors. And after that, it's for free. And after that, they will usually refer them to Integrity Senior Services, which they do take insurance for in-home counseling. We do have some good feedbacks and some okay feedback, but I think generally family, they like these services since the patient can get some social interaction in the home with a professionals.
There's also another program that we forgot to put here, which is called Connect to Culture. For example, there are organizations like Intrepid, the Cloisters, the museums in Brooklyn, MoMA. So they actually sometimes offer like an afternoon or a morning that a patient that has memory loss can go with a caregiver to participate in some of their activities. What they do is they set aside a certain time. And it doesn't happen every week, but sometimes it's like every month that they may have an activity. I know the Intrepid has something like that, the Cloisters. So there are different organizations that volunteer to join the Connect to Culture. Who's gonna do the Social Security?
You?
Okay, fine.
Okay, good.
Social Security, sometimes when we have patients that come to us, we just want to clarify, if a person is over 65 years old and has like a 10-year work history, they qualify for Social Security, which is like retirement, a pension. If a person, let's say, is 35 years old, has never worked because they have been disabled, or they just never worked enough years, they can qualify for Supplemental Security Income, which is SSI. If a person, let's say, is working and they're like 58 years old and they have some years of working, usually it's about 8 or 9 years, okay, and they become disabled, then they can qualify for what is called Social Security Disability Insurance. Sometimes our patients that we get at the clinic, they may have 1 or 2 of them. Most of them just have the regular Social Security retirement, providing they work the 10 years, in New York City, okay, or New York, wherever it is, they work 10 consecutive years. But sometimes we have patients that may have worked only a couple of years and then what they get from the Social Security is very low, so then they supplement that income with the SSI. So, and that's important to know because that's what helps us determine whether the person should do the pool income trust or the spend down with Medicaid. What we encounter sometimes is that the caregivers are guarded to give us that information, and we try to explain to them, we don't need to necessarily know the personal business of the patient, but it would help us make an informed decision, and it would also help you make an informed decision as to which way you should go, whether you should do the pool income trust or you should do the spend down with Medicaid.
Mhm.
And we also,
Go ahead, Andy.
so I think we also have a lot of people also who have a diagnosis of dementia, and sometimes they are being referred to the clinic just to get a citizenship waiver. So that is something also that the doctor fills out. Sometimes they do require them to actually compare the to visit to see whether or not there's any changes in memory. So, but usually this is a form that the doctor fills out with the assistance of the social workers, just to actually guide them to what they should, whether or not they could get this form filled out for them. It's a good way of getting citizenship if they don't have citizenship yet, if they are a green card holder and they want to become a citizen, so they can be waived the exam, the civic exam, and the English literacy test because of memory. We do have an increase of demand for that. I guess lawyers have been referring people like crazy for this paper. It does take time to fill out, but this is one of the things that we do. If the person really needs it, we have to fill it out also.
I think Dr. Gerard raised her hand.
Oh, okay.
Oh.
I don't hear her.
Hello?
I think she's working on it.
Okay.
Oh, okay.
Dr. Gerard, did you?
Can I unmute? Maybe she's still muted.
She's still muted.
Okay, I got
Okay.
another call happening in a couple minutes, so it's starting to crowd in. But anyway, I was wondering if any of these services were available in easy access ways for people. I'm thinking now about some of the challenges with people not being able to get out to them. I take the library, for example. I know my library has a lot of things that they're putting online for people, and so does the senior center here, I think. But I'm wondering if anything like that is available, if you know about anything like that for these bizarre times that we're in. And then how many of are the people that you see in these in your practices have access to materials so that they can do Zoom or other electronic engagements?
Well, I can tell you that, since we've been doing the evaluations at the clinic, it's really difficult for some of the seniors to access these services if they don't have the connection or the internet. So that is a problem because, we can tell them about the services, and unless their caregiver or their family member is around that can actually, put on the computer and connect to the services, it's a challenge for, I know, a lot of our seniors. I just actually, Friday night, I found out that Lincoln Center is actually having like operas and movies and shows online to help people relax. So that's actually good. Alvin Ailey is also doing the same. A lot of the dancers are doing certain dances at a certain times and things like that. So a lot of the organizations, in New York City are trying to provide services, but I think our seniors don't have the access to enjoy some of those services or participate in some of them.
Yeah, if the caregivers are around or they live with the patients, we are able to share the links and resources via email to them. But if the patient lives alone and do not have internet access, it's harder to provide the
Yeah.
resources.
I mean, this whole situation has raised the accessibility. We paid a lot of attention to it around kids and homeschooling and
Right.
their access, but I really think it's something that we need to think about for, you know, people who are disabled or people who are frail elderly, or when none of us are allowed to go anywhere.
Absolutely. I mean, I think that this whole experience raises all sorts of issues, but not the least of which are ADA-like issues, structural issues, right? Access to everything should be maintained in the event of these emergencies, or just in every regular everyday life.
Yeah, well, and it even becomes more important now.
Absolutely. We have to probably move the way of internet becoming a utility.
Yeah.
Quite frankly.
Yeah.
And it should be guaranteed.
And
so
get these and get these bloody companies that make the hardware when you go in to have something fixed and it's 2 years old to tell you that you can use it again.
Right.
Instead of buying a new one.
Or, you know, making the buttons senior friendly, age friendly, so that you can, if you have mild arthritis in your hands, you can actually use the technology.
Well, maybe we should apply for a grant with Apple to do something.
Absolutely.
All right.
Absolutely.
So with we also get a lot of demands for housing referrals to like NYCHA or help the seniors to get senior housing. Unfortunately, with NYCHA application, there's like a long wait list. I believe it's like 6 to 10 years of wait list for NYCHA application. And for affordable housing, we're able to submit application for the patient. It's a lottery base and also an income base. So if a patient is only
I'm sorry, that was 6 to 10 years, not 6 to 10 months?
No, 6 to 10 years.
Yes, just
in New York.
It's the same with the senior housing. One, we know that there's a shortage of senior housing.
Yes.
Okay, so that's a big problem. And then they also have like a long wait list.
Yes.
They do.
Yeah. And then I know, Clivia, do you want to mention about share housing and share residence?
There are some programs. One is called share housing. For example, if I have a home or I have an apartment that has an extra bedroom and I want to invite another senior that needs housing to move in with me, what they do, there's a program in Manhattan, and I have the resources at the office, so I apologize for not having the name of it here, but then they interview us, like they would try to match, and if it's a good match for both of us, then the senior can move into my home, and in the home we would share the expenses. And that's one program. Then they also have shared residence, and they also have this in Staten Island. Integrity Senior Services was the one that pioneered this program, that they may have like a house and that the landlord wants to rent out. So what they do is they may put like 3 or 4 different seniors in that same home, and then they have like a case manager assigned to that home to ensure that the seniors are being taken care of, that if they have home health aid, that the aides come and, you know, take care of the seniors and things like that. So there are a lot of different strategies being used to try to link up people that need housing with other people that have apartments or homes that are available. A North community, for example, is a community that a lot of the seniors are already 60 years and over, and what they try to do is they try to have a senior center attached to the development, and they also have like a social worker attached to the development too, because what happens is...
So NORC stands for, just for everyone else on the call, a naturally occurring retirement community.
Yes.
Yes. Sorry, I should have put it.
Yeah. Thank you. And then with the homeless shelters, as we know, dealing with homeless families, and I worked with them for many years, it really is a problem, unfortunately. But when you're dealing with single adults, especially those that may have memory loss, it's very, very complicated. For example, right now there are only 2 sites that are homeless shelters for veterans. And we all know the number of veterans that there are that are displaced and homeless. So sometimes the our patients may not necessarily end up at the right shelter. But I do know that it is, sometimes they have to be at the shelter system, like 8 or 9, 10 months before they can get a voucher to then seek permanent housing. So that also is a long, long process. And just because you have a voucher does not guarantee that you're going to get the apartment, because the lady or the owner of the home can actually just, you know, screen you and say this is a match or this is not a match.
Yeah.
Any questions about our
Yes.
presentation?
We're
Oh, go ahead, Vicky. We got another page. I
Yeah,
forgot.
one last page, a very
Okay.
important page. So with every new patient, Clivia and I and Andy, we always make sure to introduce advance directive, and the doctors too. We always introduce advance directives to the family, at least to get them start thinking about having a proxy done or power of attorney. I think in New York State, we have healthcare proxy, living will, and do not resuscitate as part of the advance directive documents. So at the clinic, we have the healthcare proxy ready. So usually we speak to the family and the patient to like explain to them what this is about. And a lot of times they are willing to do the form right away. Clivia and I and Andy, we are able to be the witness to sign off. However, we always explain that if the patient is not at a capacity to or understand what he or she is signing about, we are not able to complete the proxy form. So if that's the case, the family will have to go through the guardianship in order to get the power of attorney and everything in place. With a healthcare proxy, also, if a person they wanted to designate, they can designate 2 agents on the form. However, they can change. It's not an indefinite agents. They can change the next day if they change their mind. So with the healthcare proxy, I think there's more flexibility to it. And for the most, I think that's usually the doctor who has to, I think they have to sign, I think, right, Clivia?
Yeah.
I've never done that before, but I know we have patients asking for the form.
Yeah, I help them fill out the form, but then I get the doctor to sign off on it based on what the patient wants, you know, because it does cover like all the different, you know, they want medication, they want life support and things like that.
In some states, this is called a POLST, physician order for life-saving or provider order for life-saving treatment. It does require a licensed medical provider to sign off on. Yeah.
You know, something I also want to bring up is that, I forgot to mention it earlier, is that sometimes we have patients that come to the clinic with a caregiver. It could be like the home health aide. And sometimes, you know, a challenge we encounter is that we would like to speak actually with a family member, because the family member, be it the spouse if they're still married, or a child, can make the decisions for the patient. A caregiver cannot make the decision for the patient. And sometimes we have to be mindful that if it's only a caregiver, that's why sometimes we ask them, do you have the name of the children, or do you have the name of a significant other, or the healthcare proxy that we can call? Because we cannot really just get all the information from the caregiver, because we had a case in particular that the caregiver was providing all the information, but it was basically based on her own interests. So we have to always be careful when we're dealing with the patient and whoever comes with them to the session.
Andy, you want to talk about power of attorney? I know there's long version and short version.
Yes, so power of attorney is actually one of the most important documents for the population that we are dealing with. It's a simple form that can be done and signed by witnesses, or sometimes you can go to a lawyer and get it done. Basically allows a person to manage your finances and everything, or make decisions on their behalf. If the person has dementia, they definitely need this. Even if you're a spouse, you cannot make certain decisions
Mhm.
And they're not gonna give you information. So this form, I think it's not because someone has dementia also. Everybody should have a power of attorney just in case they need it. It's just like how I explain to caregivers, like it's like having car insurance. So that doesn't mean that you're going to have an accident the next day, but it protects you in that case. So same for power of attorney. That doesn't mean that somebody's gonna manage all your assets and your finances, making all decisions for you. But in case you need somebody to do that, then this is the protection that you have. Then you have somebody who can access your financial record or make decisions for you for your own benefit. Um, so we recommend the durable power of attorney, so the one that actually so you don't have to change it. Some version you can actually modify it, or you can put limitation to it. Um, but um, but for the population that we are dealing with, we recommend them to um, give away all the powers so that whatever the person needs to do, they're allowed to do it, so that there's no limitation. Um, to show you the importance of this form, if it's not done and the person with dementia lost capacity to make decisions, now you're going to have to go to a longer process or an even more costly process of guardianship. It will take some time, and it will take, you have to pay some fees also, and you have to go in front of a judge to actually get guardianship. So it can be done simpler by having a power of attorney, and we do refer them to agencies that are helping for free, depending on their financial situation. Some people, they can afford an attorney who can do this for them, so that's great. But if they can, we can look for resources and we can refer them. But this is one of the most important documents that they should have as advanced directive, because it can save a great deal of stress when it comes to applying for benefits.
What we also have to be mindful is that sometimes people are reluctant to fill out the power of attorney because they think that their loved one or their family or their child is trying to basically just take control of all their money. And also what's important to understand is that banks sometimes have their own power of attorney. So even though you have a power of attorney, the dual one that Andy mentioned, the bank may require their own because they want to ensure that the person is not being coerced or tricked into signing those documents. So sometimes the bank wants you to go in person with an ID, and they actually will talk to the patient, the account holder, to make sure that they know what they're signing off or what they're doing.
Should I skip the last part? I make that.
I would add just one quick comment that I hope, I don't know if it's exactly a positive outcome from the pandemic, but I hope one of the outcomes from the pandemic will be that people learn of their own mortality and accept that they should be preparing these documents ahead of time,
Right.
so that they can be prepared for unexpected health outcomes.
True.
And I think that's maybe a discussion we have to have. As much as we're not going to want to talk about the pandemic when it's over, we may have to remind people of how much danger we're all in to get people on board with these things.
I know when Etin and I go to the senior centers to talk about dementia and Alzheimer's, I know that both of us do cover these topics, and we explain to people what it is and the importance of having these documents. Because I was actually hearing the news the other day that a lot of more people are now filling them out as a result of the pandemic.
Okay.
Any questions? Go ahead. We have one more slide. Go ahead.
I think I
Yeah, it's the last.
typo. Sorry.
It's
It
all
should
right.
be above the sunny side. So there are caregiver initiative programs in New York City that do provide like support group, or like we apply for medical ID bracelets and the respite care, as Andy mentioned earlier. So these are the organizations that they receive funding other than AFA. they do receive state funding to provide these resources for free. Anything else you guys want to add?
No.
Okay.
I mean, there are a lot of other programs also in addition to Sunnyside that do assistance. Like in the Bronx, I know it's RAIN, this PSS. This,
Yes.
right, so they have them throughout the whole city. It's not just, you know, Sunnyside and Queens. And, you know, so like now a new initiative is what they're trying to develop is what they call the dementia-friendly communities. And I know that there are programs that are trying to actually create the dementia-friendly communities within New York City. So, any questions, comments, feedback?
Nope, thank you for the information. No, thank you for the information.
Thank you all for taking, I thought I was muted, but I wasn't. Thank you all for taking the time to do this. It's really important stuff.
Yes.
Thank you.